Assalamu alaikum, good morning. Thank you for having me. My patient is a 69 years old male who's known to have diabetes, hypertension, dyslipidemic, presented to the clinic with a typical angina class 2 and shortness of breath for the last 6 months. He was on optimal medical therapy, aspirin, Plavix, aspirin, beta blocker, isosorbate nitrate, Lipitor, and ezetimibe. Despite of that, he was still complaining of chest pain and shortness of breath. His baseline ECG showed no significant SDT changes. His echo was within normal limit except grade 1 dissect dysfunction. Nuclear scan showed moderate ischemia in the anterior and anterolateral wall. So after discussion with the patient, we opted to go for coronary angio to rule out significant coronary artery disease. And as you see, he was having almost reversible disease, proximal LAD, circ, and borderline RCA lesion. IFR done to the proximal RCA showed no significant stenosis physiologically. So after discussion with the patient, he agreed with PCI to proximal LAD and circ. So LAD was wired, pre-dilated, lesion prepared with a 2530 balloon, and then stented with drug-eluting stent 27548 with a little bit good post-PCI result. So we were a little bit obsessive about post-dilatation, so we opted to choose 3-5 NC balloon. We go with a pressure of 18, although there was no significant calcification. After inflation at the edge of the stent, we had a significant perforation. So the bleeder was controlled with repetitive inflation of balloon to control the bleeding for around 15 minutes. Patient remained hemodynamically stable and stable, but still he was having significant leak. So decision was made to go ahead with a cover stent. We deployed 3-5-16 to control the bleeding. Despite of that, patient have some leak, but we were lucky that he was not in hypotension or so we're pushed to overlap another stent, as you see, proximally to control the bleeder.
You put the pericardial drain?
On table, we did echo simultaneously. There was no significant pericardial effusion, although we use a single catheter exchange for cover stent and balloon, and we're lucky to control the bleeding. Patient remained in the CCU for 48 hours, didn't have significant
So you contained
pericardio.
You treated very quickly, looks like.
Yeah.
Patient did not go in terms of heart.
Yes.
How long time you had? Did you have the balloon in when you actually put the stent in? And then you saw the perforation, you still have the balloon in the guide cath?
Yeah. We keep it for repetitive inflation for 2 minutes, 1 minute, control ischemia. And after 15 minutes, we exchange it with a cover stent. We know that it's better to have another access and another catheter to replace it quickly, but we proceed with the cover stent through the same catheter. Patient remain in the CCU.
There's one more question.
Sure.
Congratulations for seeing that operation. Question: if you go back, the same case, and you had the IFR, uses the RC. If you do the pullback, you just diffuse the disease and the heat, and you saw the IFR curve growing gradually, slowly, without any step. Would you give him another trial of medical therapy?
Well, I think he remained 3 to 4 months on medical therapy, but he's still symptomatic. And after coronary angio, we discussed that it's a stable coronary artery disease, but he might get benefit of symptoms. And because the proximal NAD is a prognostic visit, we chose to stent it.
Would be anything helpful to know the size of the vessel before going to the stenting?
In such case, we might go ahead with pre-dilatation, preparation of the lesion, and stent it. But I think this is good point, but it's not practical to do it for every single patient.
Yeah, go ahead, Dr. So initially it was mentioned that he had a very few symptoms. He had angina class 2,
yeah,
not class 3 or 4. Like, could have been easily managed at the optimal medical
yes, but we have physiological, we have thallium, which showed moderate ischemia in the anterior and anterolateral wall, which pushed us to go.
And second question, once you put in the 27548 stents,
yeah,
what pressure did you go up?
I didn't get your question.
Inflation.
Yeah, we inflate with the post dilatation. You mean the NC balloon? Yeah. We inflate with the 3.5 stent up to 16 to 18 atmospheric pressure.
The initial stent that you put at 275.
Yeah.
48.
Yes.
Which he's asking what was the pressure? Yeah, what was the pressure that went maximum?
Well, I think we shouldn't escalate it up to this number, but sometimes we are so obsessive about the proximal LAD. It should be bigger in diameter, but that's what was happened.
So Ahmed, you want to ask?
Yeah, just to comment, I think this is type 3. This type 3 will be time to close with just one alone. We are wasting our time because usually not respond to balloon inflation for a long time. So we can just control by alone until we are ready for the cover stent, and immediately we can use the big bone technique to immediately deploy cover stent.
It's all about lesion preparation. While you prepare you do it, you will not need to go to high pressure.
Yeah.
And you can avoid it.
Did you reverse anticoagulation?
No, in this patient we didn't because we had fresh stent and. Yes.
You were lucky.
Yeah.
Exactly.
This is nothing. This is not the case that we have with us.
Yeah.
Immediately you will have pericarditis.
Yeah.
You want to
Which grass stent did you use?
Okay, do you want to continue? Then we'll ask for this is your final.
It's okay. We are about to finish.
Yeah.
Just a few talk about.
Yeah. So we can allow for discussion, please.
Sure.
You see, in the pre-NGO, there was a diffuse disease. And,
yeah.
For me, it was acceptable.
Yeah.
That's why we learn.
Although it's not predictable, but we have to accept it. So restriction of the vessel size, restriction of the calcification is very important. Early detection of the coronary calcification will mandate gentle manipulation and ablation. Caution is needed while advancing wire and dilation of the coronary vessel. Once it happens, don't be panic. Just control it with the balloon that you have. Think and do simultaneous echo to rule out any significant pericardial effusion. As you know, we have 5 types of perforation. As the doctor mentioned, that type 3 with the active tip extravasation, and type 5 is a distal perforation. Usually, the management of each type is different from the other, but the most common management way is the cover stent. Unfortunately, we don't have much data about the safety and about the duration of double antiplatelet therapy and the risk of atherosclerotic complication in the future, but this is the only option that we have. There is some limitation with the cover stent regarding crossability, but it's better with the second generation. About the sizing, about slow inflation and deflation, and side branch failure with thrombosis. And as we mentioned, there is no much data about the duration of double antiplatelet and the risk of thrombosis, restenosis, and atherosclerotic. We kept our patient on double antiplatelet, and we advised him he should go lifelong on the double antiplatelet. Thank you very much.